And so with that, I want to pass the baton over to Dr. Andrew Aronson, who's an associate professor of medicine at the University of Chicago Medical Center. Dr. Aronson's a practicing hepatologist and a prolific researcher on viral hepatitis, and he serves as the co-chair for the AASLD IDSA HCV Guidance Committee. So he's going to talk to us a little bit about efforts underway to simplify hepatitis C treatment.
So thanks so much for this invitation to speak. I'm really, really excited, and all these presentations leading up to this, hopefully I can shed a little light about what the HCV guidance can offer in support of this. Next slide, please. All right, I don't have any disclosures except I'm one of the co-chairs of the HCV guidance. So hcvguidance.org, hopefully many people on this webinar are familiar with this. And this is a document that is online that has all of our recommendations regarding hepatitis C care and treatment that you can find really in one place. We like to think of this as a one-stop shop. Next slide. So our guidance was actually started back in 2014, and just a little bit of history about this. It was really coming out of emergence of the DAA therapies. And what we realized is that these new medications were coming online really fast. And what were we going to do for providers who are on the front line of care? It wasn't really practical to wait a year or two for a journal article or guidance to come out. So what we did is the folks on the AASLD and IDSA teamed up for this combined document that we could really use together and create true real-time clinical guidance for providers. This was meant to be a living document that we would update with new evidence as it came along. And there is a publication every other year, but really this was supposed to be, something that you would refer to when you're seeing a patient in your clinic and you really want to know what the best treatments to use are. Next slide. Just very quickly, the governance. This is co-sponsored by the AASLD and the IDSA. We have co-chairs on each side and panel members representing hepatology and infectious disease. We also are fortunate to have community partners and members of the CDC who also help advise as far as our recommendations. Next slide. It's pretty popular. We have, last time I checked, had about 2 million individual users going to our site. And it's available everywhere because it's online, but we have documented usage in over 200 countries. But I will be clear, especially when I'm getting into some of the discussion around elimination, that since this is a US guidance, we're focused on treatment recommendations for the United States. So we use medical regimens that are available here in the United States. So it is US based, but certainly could many countries and folks in other countries have used this as a resource. Next slide. And here's just for those of you that are less familiar with our guidance, I just wanted to kind of show what it looks like. And what I really would like to hit home is what we hope is a hugely practical resource. So this is a very easily navigatable website online where you kind of hover over the characteristics of your patient regarding their treatment status, their genotype, things of that nature. And the first thing that will pop up is this very easy to read box with all the treatment recommendations, as well as duration of treatment. And then the evidence rating is written there. And as if you were to scroll down on this website, you would see all the clinical trials that have led up to lead to these recommendations. So you could, you can see the data yourself if you're interested. Next slide. And this is the groups of people for our treatment recommendation. Many of them used to be called special populations, but it's really just so good that they're not special anymore in the nicest possible way. And what I mean by that is these were difficult to treat and patients based on some of the comorbidities that they have. But now everybody is easy to treat. So when we're moving towards elimination and certainly thinking about new diagnostics, it only really makes sense if you can treat everybody. And I'm really, really excited to say that we can absolutely treat everyone, both treatment naive and treatment experienced, but also people with cirrhosis, including decompensated cirrhosis, those who are co-infected with HIV, acute hepatitis C, renal impairment. There's emerging data of treating people during pregnancy. as well as children down to the age of 3, and as well as people who have received transplantation, including with hepatitis C positive organs. We also have a newer section that that outlines what you should do as a provider if someone has a treatment interruption, whether they've lost their medication or had trouble getting refilled or some other issue happened, and how to go about managing that patient that's had an interruption. Next slide, please. All right, so really what I want to get to is the importance of this point of care test. And what I hope to drive home in the next few minutes is really showing you what this means and what this is going to look like in the clinician's hands, and how we are going to support this from the guidance to really incorporate point of care testing and guidance that many people use every day. So standard of care testing, and this has been shown in a few different ways through the past few presentations and different permutations, but standard of care testing has some drawbacks. So let's say a person comes in for testing, maybe in a provider's office, but maybe somewhere like a harm reduction center or an addiction center. And then let's say they have to wait for their test to come back positive. And then someone calls them and tells them to go to the hospital or a doctor's office or some other place where they can get treatment. And then sometimes even another confirmatory test is made, and then they have to wait to get treatment, and then they have to follow up after treatment. And as we know, and again, this has already been presented, each step of the way, you're going to lose patients. And when we're really serious about eliminating a disease, we can't afford to have those steps. So next click, please. So what we want to support, and I think that the whole point of why we're doing this webinar and all this fantastic effort that's gone into this, is test and treat point of care. So what we are aiming to do and to help advise clinicians is test and treat, meaning a person comes in to a place, and that place could be a doctor's office, but definitely could be a van, or it could be a syringe exchange program, or could be a methadone clinic, where they offer the testing, and a point of care testing is key for this. And once that's deemed positive, then the medication potentially is waiting for them right there. So they're going to get the diagnosis, get counseling, get their evaluation, and leave with the medicine in their hand. And what you've done by doing this is eliminated about 5 or 6 steps where somebody, especially a vulnerable patient, can get lost to follow-up. Next slide, please. So where's the data to do this? Are we just crazy on the guidelines and we're just kind of making things up as we go along? Hopefully not. And this is the MinMon study, or what I call the keep it simple stupid study, but there's certainly nothing stupid about this. In fact, it's quite genius. So this is a large study that was published about 2 years ago, where they take a group of patients and did no pretreatment genotyping. They determined whether they had cirrhosis by using a FIB4 test. All treatment was provided at the time of entry, so when they first met them, which is exactly what I'm talking about. They had no scheduled treatment labs, except for just 2 phone calls along the way. So they got 12 weeks of sofosbuvir and velpatasvir, and there was a phone call at week 4 and a phone call at week 22, and then they came in to have an SVR checked 3 months after they completed therapy. So really, really low touch here. You saw them once, and then you really saw them again when it was time to check to see if they've been cured. Next slide, please. So did this work? And it really not only worked, it was pretty phenomenal, the types of results we saw from the MinMon study. So overall, out of 399 patients treated altogether, so a relatively large study, 379, 95% were cured. This held true for people who are mono-infected with hepatitis C, as well as those that are co-infected with HIV. Next slide, please. But what about folks who have substance use disorder? So people with previous substance use disorder were cured. And even there was a small number, there was 12 patients, but 11 of 12 that had ongoing substance use were cured as well. And that really drives home that there should be no patients that are excluded from these test and treat protocols. Next click. And everyone asks, well, what happened to some of these patients? 3 people lost their medications. That's not so bad. And 2 patients discontinued. And I think that speaks to how safe and easy to take the DAAs are. Next slide. So we did something a few years ago where we simplified the HCV regimen. And these are what we call our one-pagers, which you can find on the initial landing page of our guidance. And what this is ideally there's a link to a PDF, and there's one for patients with cirrhosis, and there's one for patients who do not have cirrhosis. And without going through each step, this really takes you from who would be eligible for a simplified treatment, what tests you need to send in the workup, what are the regimens that are available to treat, what is the monitoring, and finally, what do you do when you're checking for an SVR, whether they're cured or not cured, and what needs to happen after that. So this was great, and I like to think of this as a first step. But there were some drawbacks to this, and that is that it actually requires at least 2 trips to the provider. This is really, since there's a lot of phlebotomy going on here, this is difficult to achieve in non-traditional settings. So it'd be really hard to do this outside of a doctor's office. And of course, now we have this great technology. It does not incorporate into a point of care testing. Next slide, please. So how is this going to fit into elimination? And when we thought about point of care testing and supporting elimination from the guidance, there's really 4 buckets, but I really want to hone in on this first bucket is we are going to be writing a new section, which should be published very soon. I'm going to get to the algorithm in just a moment about how to do test and treat, and this will be included in our guidance. So there'll be an actual algorithm utilizing this point of care test in our guidance. We don't have hepatitis B point of care testing yet, but there will certainly be updated when that's available. But a couple of other things, we do want to serve as a resource to optimize care delivery, especially amongst marginalized communities. So what kind of resources will be helpful for providers that are trying to incorporate microelimination in their own communities? Evidence that's going to desensitize centralized hepatitis C care, meaning what kind of evidence can we use and support by using other places to treat hepatitis C, and this gets into a lot of our non-traditional settings. And then finally, any new research going on in hepatitis C elimination strategies is going to be really important once it has data that supports it. And this gets into vaccines, long-acting injectable antivirals, and things of that nature. So next slide, please. But what I really wanted to finish off with is what our algorithm is going to look at. This meeting is about a week too early because we have approval for the AASLD, and we're just waiting on approval from IDSA to make this publicly available, the actual algorithm itself. But what I am able to show you is what it's going to look like, and this is going to be available on our HCV guidance website, which will be our test and treat algorithm using point of care tests. So what will it look like? The first step, of course, is going to use the point of care hepatitis C viral load and other point of care tests, including HIV and pregnancy, that are already available. Then the recommendation is going to be to take a good history, where we'll ask pointed questions looking for decompensated cirrhosis, prior hepatitis C therapies, HCC, and of course, doing a good medication reconciliation. Then the next step will be a blood draw, but the caveat here is this is a blood draw where results will not be needed during that first visit. So an AST, ALT platelets will be needed to calculate a FIB4, and a blood draw to check for hepatitis B surface antigen if this point of care is not available. But again, this blood can be drawn, so meaning you don't need patients to wait for the interpretation of the blood draws or the results to come back. It just needs to be cooking. And then most importantly, the therapy is given during that initial appointment. Results will be followed up in the interim regarding hepatitis B and treatment if needed for that, as well as what happens if somebody is found to have cirrhosis by FIB4. And then an SVR check at the end of treatment, at 3 months after the end of treatment, to determine if somebody is cured, as well as further follow-up if they have hepatitis B or cirrhosis. So again, this is going to be very clearly displayed in an algorithm, so providers all over can use this and then adapt this to their own practices where they're taking care of patients. Next slide, please. All right, so that's all I have. I want to really thank everybody for their time and this amazing effort to get this test available. As a representative from HCV Guidance, we're happy to support Hep C elimination by simplifying treatment. You know, we can't do this without point of care testing. We're never even going to get close to being there. So we're absolutely thrilled that this is available. So very stay tuned, because we will have a hepatitis C elimination section, but even more close to now and very, very soon, we're going to have our algorithm posted that's going to have exactly how to utilize point of care testing. That'll be free and available to all providers taking care of folks with hepatitis C. Thanks again for your time. I really appreciate it.